All right, let's get right into it. We are going deep inside one of the most complex surgeries there is, a lung transplant. But we're not going to focus on the surgeon's hands. We're looking at the person walking the ultimate tightrope, the one managing every single breath, beat, and drop of pressure, the anesthesiologist.
You know, a lung transplant is just an incredible feat of modern medicine. But here's the thing that might surprise you. The most dangerous, most delicate part of the whole operation isn't the cutting and sewing. It's the breath. It's all about protecting that fragile new organ from the very first moment it's connected.
So, let's walk that tightrope together. Here's our roadmap. First, we'll talk about the ultimate balancing act. Then, we'll cover preparing for launch. After that, we'll get into the Lung Protection Playbook. We'll look at the ECMO Revolution, and finally, the make-or-break moment, bringing the new lungs online.
Okay, let's start with that ultimate balancing act. This is all about protecting both the patient and the priceless new organ. See, the anesthesiologist is juggling two massive responsibilities at the same time. Job 1, keep a critically ill patient whose own body is failing stable and alive. And job 2, which is just as crucial, protect that new donor lung, this incredible gift, from any hint of injury.
And the number one threat they are fighting is something called primary graft dysfunction, or PGD. Just think of it as a massive sudden injury to that brand new lung that can happen within the first 3 days. It is the single leading cause of death early on, and pretty much every single decision the anesthesiology team makes is designed to stop PGD from happening. The stakes are just incredibly high.
So how did they even begin to prepare for a fight like that? Well, that brings us to our next section, preparing for launch. This covers the intense pre-op assessment and the absolutely critical induction phase. Success here is all about getting everything perfect before that first incision is even made. It all starts with a deep dive by the entire team. They look at absolutely everything. The lung allocation score, that tells them how urgently the patient needs the transplant. They look very closely at the right ventricle of the heart and the pressure in the pulmonary artery. Why? Because the right ventricle is the chamber that pumps blood to the lungs, and in these patients, it's been under enormous strain. It's a huge risk for failure. They analyze scans to decide which lung to replace first. They even look at the patient's overall frailty and nutrition. Every little detail matters. And all this planning leads to a moment that our source material calls one of the most critical periods of the whole surgery, putting the patient to sleep. So why is this specific moment so dangerous? Well, you have to remember, this patient is incredibly fragile. The combination of powerful anesthetic drugs and the start of mechanical ventilation can cause their blood pressure to just plummet, leading to a sudden and catastrophic cardiovascular collapse.
So induction isn't just about going to sleep. It's more like a highly controlled launch sequence. First up, everyone, the surgeons, the life support team, is on high alert, ready to jump in with something like ECMO at a second's notice. Next, they do everything they can to optimize blood flow, sometimes using inhaled drugs like nitric oxide. Then, they give the anesthetic drugs themselves, like etomidate and rocuronium, in tiny, carefully measured doses. And finally, they secure the airway with a special piece of equipment called a double-lumen tube, which is what lets them ventilate just one lung at a time later on.
Okay, so once the patient is safely under and the surgery is underway, the whole game changes. This brings us to the Lung Protection Playbook. This is a very specific set of rules, all designed to shield those new lungs from harm and prevent that PGD we talked about.
And here's the key. The goal isn't just to pump oxygen into the patient. The goal is to actively prevent the ventilator itself from causing injury. You have to imagine this new lung tissue is unbelievably delicate, so the whole strategy is to minimize any and all stress and strain on it. So how do they do that? Rule number 1, use tiny breaths. On the ventilator, this is called a low tidal volume. They're setting it to deliver just 4 to 6 milliliters of air for every kilogram of the patient's ideal body weight. It's not a lot of air, but this is probably the single most important thing they do to avoid overstretching and damaging those fragile little air sacs in the lung. Rule number 2 is all about pressure. They aim to keep what's called the plateau pressure under 20. Now, this isn't the pressure of air flowing in. It's the static pressure that's held inside the lung for just a split second at the end of a breath. It's a direct measurement of the stress on the lung tissue itself, and keeping that number low is an absolute must.
Now get this, because this one sounds completely backwards. The moment that blood flow is restored to the new lung, what's called reperfusion, they actually keep the oxygen level low, below 30%. You'd think you'd want to blast that new lung with pure oxygen, right? Well, it turns out that a sudden rush of high-concentration oxygen can trigger a toxic reaction, damaging the very tissue you're trying to save. It's a huge risk factor for PGD.
All of these rules lead to this fascinating strategy called permissive hypercapnia. What it means is they actually let the carbon dioxide level in the patient's blood climb a little bit, as long as things don't get dangerously acidic. Why on earth would they do that? Because trying to get that CO2 number perfect would mean using bigger, faster breaths from the ventilator, which would increase the mechanical stress on the new lung. They are choosing to protect the organ over having perfect numbers on a screen.
Now, as you can imagine, trying to manage all of this is an incredible challenge. And that brings us to a piece of technology that has absolutely revolutionized lung transplants, ECMO. So let's talk about the ECMO revolution and how this advanced life support works in the OR.
For a long time, the standard machine was the heart-lung bypass machine, or CPB. But today, most big centers prefer ECMO, which stands for extracorporeal membrane oxygenation. And the reason for the switch is pretty clear. ECMO needs a way lower dose of blood thinners, so there's much less bleeding. It causes less inflammation throughout the body, which means less PGD and fewer kidney problems. Plus, if the patient still needs support after surgery, it's way easier to just keep the ECMO going. It's just a smarter, gentler way to do it.
So how do they manage a complex machine like that with such precision? With this amazing tool called a transesophageal echocardiogram, or TEE. The best way to think of it is as a real-time internal sonar for the anesthesiologists. With this probe, they can literally watch and confirm that the ECMO tubes are in the exact right spot. They can see how the heart is handling the stress. They can spot dangerous little air bubbles before they can cause a stroke. They can even get a look at the surgeon's stitches. It's like having eyes inside the body.
All right, now we come to the climax of the whole operation, bringing the lungs online. This is it. These are the final, incredibly delicate steps leading to the very first breath of that new organ.
And this is not like flipping a switch. It's a carefully choreographed dance. So before reperfusion even starts, they're giving powerful immunosuppressant drugs and antibiotics. Then, just moments before blood flows into that first new lung, they give a drug called mannitol to help shield it from injury. Then, the surgeon slowly opens the clamp on the pulmonary artery, taking a full 10 to 15 minutes to let blood flow in gently at low pressure. As that's happening, the anesthesiologist starts ventilating the new lung using that low oxygen and all those protective settings we talked about. And only after the TEE confirms there's no air trapped in the heart can they even start to think about weaning off the ECMO machine.
At the very, very end of the surgery, there's one last critical move. That special double-lumen tube has to be carefully swapped out for a standard breathing tube. And this has to be done incredibly carefully, because after a surgery this long and complex, the airway can be pretty swollen. This final step gets the patient ready for the move to the intensive care unit.
So when you really step back and look at it, the success of a lung transplant isn't just about a gifted surgeon. It is a testament to this unbelievable, second-by-second management of the patient's entire body. It all comes down to obsessive planning, constant real-time problem-solving, and just seamless, flawless communication across the entire team. It's really a stunning thing to think about, the level of complexity that modern medicine can actually master. When you see how they can protect and integrate a new organ with this kind of precision, it really makes you wonder, what's the next frontier? What does the future of organ transplantation even look like?